Today's training reviews the adopted revisions to Part 524 Incident Management Regulations, effective October 29, 2025. The former Part 524 regulations were adopted in 2015 after having gone through revisions with the advent of the New York State Justice Center. After 10 years, revisions were needed for a number of reasons. An audit by the State Comptroller revealed that OMH providers were not in compliance with requirements surrounding Mental Hygiene Law, Section 33.23, involving incident notifications and reports, as well as Section 33.25, regarding the release of records pertaining to allegations and investigations of abuse and mistreatment. These sections pertain to what is more widely known as Jonathan's Law. OMH also received feedback from various providers or services, state oversight agencies, and families of service recipients that led to the acknowledged need for updates. The regulations, as they stood, conflicted with the enacting statute, such as the differences between outpatient and inpatient death reporting. And finally, there was a growing need to improve the overall incident reporting process and provide clarity to the requirements. In addition to the revisions we will be discussing, the entirety of the regulations were updated by replacing gendered pronouns with gender-neutral pronouns and by updating state agency names. Starting with general definitions. The first update was made to the definition of custodian in order to more clearly state OMH's intention for security personnel to be included. OMH has always considered security personnel to be custodians. This was solely for clarification purposes. Next, the definition of reportable incident was updated to include deaths of program recipients, again for clarification. The definition of restraint was updated to include the service recipient's head as a specific part of the body. Continuing with general definitions, the definition of serious injury or harm was updated in two ways. First, the threshold of what is determined to be beyond first aid was expanded to include the use of an opioid antagonist such as Narcan when used to counter the effects of a suspected opioid overdose. This means that the use of Narcan would cause the event to be a reportable incident. The second change to the definition replaces the need for medical treatment to be provided post-test results, allowing for treatment to simply be indicated. For instance, a service recipient may refuse treatment that lab work, x-rays, or scans may indicate. Therefore, the recommended treatment only needs to be indicated, not actually provided, in order for the incident to meet reportability criteria under serious injury or harm. A brand new definition that has been added to Part 524 is human trafficking. This definition was added, as you will see shortly, because human trafficking will be a new incident type in two different ways. Human trafficking, also known as trafficking in persons, means a crime under the penal law that involves compelling or coercing a person to provide labor or services, or to engage in commercial sex acts. The coercion can be subtle or overt, physical, or psychological. Exploitation of a minor for commercial sex is human trafficking, regardless of whether any form of force, fraud, or coercion was used. And finally, reasonable cause to suspect. While this is not a new term within OMH investigations, the definition was not included in previous versions of the regulations. Reasonable cause to suspect means that based on all evidence, facts, and circumstances known or readily available, it is rational to think that a reportable incident may have occurred. Reasonable cause to suspect is a judgment about a statement, not about the condition, competency, or credibility of a patient. On to changes to incident category definitions. choking is making a reappearance as a reportable incident category. It is defined as an event where a patient is unable to breathe as a result of ingestion of food or other object which requires a physical intervention, such as the Heimlich maneuver, which 1, results in serious injury or harm or admission to a hospital, or 2, where there is a written directive for such patient concerning risk of choking that was in place at the time of the event. The definition of crime was updated to raise the age of the offender from 16 to 18 years old to align with New York State law. Next, we will see how human trafficking will have 2 different reporting requirements. The first human trafficking incident type will be an OMH-only reportable incident. This will be when a patient of an inpatient or residential youth program is the victim of human trafficking while they are on an authorized leave or pass from the program. So this incident category is for youth only who are allowed to leave the program, and while on leave from the program, they are the victim of human trafficking. If this should occur in your youth inpatient or residential program, you would need to report this to OMH only via direct entry incident in NIMERS. The second incident type where human trafficking makes an appearance is as a subtype of missing patient. The current definition for missing patient remains the same and should be reported in the same manner. However, once your missing patient returns to their inpatient or residential program, if it is determined that they were a victim of human trafficking while missing, this subtype would be added in NIMERS. This subtype is for patients of all ages, not just youth. Another new incident category is overdose. Overdose is defined as when a patient consumes an amount of a substance, whether it be prescribed, over-the-counter, legal or illegal, which is not intended to cause their own death, but results in serious injury or harm. Remember that if this action occurs with the intent to end one's life, it would be considered a suicide attempt. Moving forward, the definition of sexual assault is updated as follows. Formerly, it was defined as a sexual attack, including but not limited to those that result in vaginal, anal, or oral penetration, such as rape or attempted rape, and sodomy or attempted sodomy, and then continued with the same sections 2 and 3 included below. Now, the definition begins with it being non-consensual sexual contact, including the deliberate touching of a patient's intimate body parts, or clothing covering those body parts, or using force to cause self-touching by another patient of intimate body parts. And then the definition continues with the rest of what was originally included. Under the revised regulations, mistreatment will no longer be an incident category. And the 4 types of mistreatment will now fall under 2 different incident categories. Part 1 and 2 of mistreatment concerning the inappropriate use of restraint and seclusion will fall under the new incident category of rightly named inappropriate use of restraint or seclusion. Part 3 and 4 of mistreatment will fall under wrongful conduct, as we will see in a moment. With wrongful conduct, you will first notice that Part 3 was revised to include social media and point out that these are just examples, not an exhaustive list. Wrongful conduct was also updated to remove the example of sleeping while on duty, as this could be abuse-neglect depending on the circumstances. And then finally, you will see the remaining 2 sections from mistreatment now falling under wrongful conduct. And finally, a minor change was made to other incident so that the reporting threshold matched other incidents requiring serious injury or harm for reportability. And a minor revision was made to sexual contact between children, as this incident type already required the youth involved to be on program premises or under the intended supervision of staff in order to be reportable as a significant incident. Regarding Section 524.6, the Incident Management Program. The only change here is the inclusion of the need to document any incident patterns or trends that are identified and reviewed by the program. Moving forward with Section 524.7, Incident Reporting Requirements. The list of reportable allegations of abuse neglect in Section 524.7 has not changed, so we will start with the significant incidents. This just shows you the full list at a glance. The list of OMH-only reportable incidents was added to this section as it had formerly been under 524.10, additional incidents reportable to the Office of Mental Health. This list was moved here with the new incident categories added. Outpatient deaths were also added to this list as they are only reportable to the Office of Mental Health via NIMERS. Moving forward with incident reporting procedures under 524.8. Section A under 524.8 was updated to clarify that an incident is reportable within 24 hours of discovery, as an incident cannot be reported until one becomes aware of it. Section F, which reviews the existence of protocols for responding to patients who are frequent reporters of abuse neglect, updates the language of the assessment of report from not reasonably reliable to where there is no reasonable cause to suspect. Again, the definition for reasonable cause to suspect was added to the general definition section. Finally, Section H specifies the manner in which OMH expects providers to receive incident notifications from OMH, specifically via a dedicated electronic mailbox. This is not a new requirement, as OMH has requested that all providers update MHPD, the Mental Health Provider Directory, to include a generic email that multiple staff can access for the purpose of receiving communications from OMH's Office of Quality Improvement. Section 524.9. Incident investigation, corrective actions, and records maintenance includes the following revisions. Under investigation process, C4, commencing the investigation, it is further clarified that witness statements, interviews, and interrogations are not to be conducted, and written statements should not be taken by anyone other than the investigating entity for allegations of abuse, neglect, or deaths. Under final reports, death reporting, language was added to clarify that closed death reports shall be reopened once the autopsy is received, and the cause of death should be updated as needed. Section 524.10, additional incidents reportable to the Office of Mental Health. This language was updated as the list of OMH-only incident types, as you remember, was moved to the full list of reportable incident types outlined in 524.7. This section states that OMH-only incident types, when they occur off-program site and while not under the intended or actual supervision of a custodian, must be reported to the Office of Mental Health in the form and format prescribed, which would be through NIMERS. Section 524.11, Patient Death Reporting. The section on patient death reporting was updated in the regulations so that it aligns with the current practice and clarifies the differences between inpatient and outpatient death reporting. The Justice Center Medical Review Board must be notified through the Justice Center Vulnerable Persons Central Register Death Reporting Unit of the death of a patient of a state-operated or licensed mental health provider who was enrolled in or receiving services from a comprehensive psychiatric emergency program, or CPEP, inpatient or residential program at the time of death, or if they should die within 30 days of discharge from the program. Any patient death from an outpatient program must be made in accordance with Part 524.10, which we just reviewed. Deaths of any patients from outpatient programs or within 30 days of discharge from the program would be reported to OMH only via NIMERS. Again, nothing has changed with the current practice of death reporting. The revised regulations just more clearly outline the process. Section 524.12, Other Required Notifications. Here is where we see the updates made in response to the Comptroller's audit on OMH providers' adherence to Johnson's Law. All of Section B regarding notifications made to patients, family, or personal representatives was removed and revised as follows. Upon admission, patients and qualified persons shall be informed in writing of their rights to receive information pursuant to Mental Hygiene Law, Sections 33.23 and 33.25. When an incident affects a patient's health or safety, or a reportable incident occurs involving an allegation of abuse or neglect, wrongful conduct, missing patient, or death, the agency must provide telephone notice to a qualified person as defined in paragraph 6 of subdivision A of section 33.16 of the Mental Hygiene Law within 24 hours of the initial reporting of an incident. The agency must not provide such notice to a qualified person in the following situations. A, if the qualified person is the alleged abuser. B, if there is written advice from the qualified person that they object to receiving such notification. The notice must then be provided to another qualified person if one exists. Or C, if the person receiving services is a capable adult who objects to such notification being made. If the capable adult objects to notification of a qualified person, the capable adult must be provided the notice described in this clause. Continuing on. At the qualified person's request, the following must be completed. Provide the qualified person with a copy of the written incident report, provided that the names and other personally identifiable information of patients and employees are redacted unless patients and employees authorize such disclosure. Meet with the qualified person to discuss the incident. And within 10 days, send the qualified person a written report on the actions taken to address the incident. This is called the Actions Taken Report, and it is embedded into NIMERS. If you complete this section in NIMERS, the report can be printed and used for this purpose. Continuing on, in accordance with Mental Hygiene Law 33.25, upon written request to the provider, qualified persons may obtain records and documents related to reportable incidents, including the results of the investigation, within 21 days of either the conclusion of the investigation or the written request, whichever is later, provided that the names and other personally identifiable information of patients and employees are redacted unless patients and employees authorize such disclosure. Regarding the redaction of documentation for this purpose, In accordance with Mental Hygiene Law, Section 33.25, incidents or allegations reported to the Justice Center shall not be deemed to be serving a quality assurance function as defined pursuant to Social Services Law, Section 490B. As such, the only information that may be redacted are names and other personally identifying information of other patients and employees, again, unless such patients and employees authorize the disclosure. In terms of documentation, the following must be maintained by the provider. 1, the telephone notice and responses received, including the identity and position of the person providing the notice, the name of the person receiving the notice, the time of the original call or attempted call, the time of subsequent attempted calls if the initial call was not successful, and the time of follow-up calls if the notice occurred in more than one call. 2, any requests for a meeting or for the initial incident occurrence report. 3, meetings held in response to the request and those present. 4, a copy of the actions taken report and any initial incident occurrence report with redaction that was given to the qualified person. And 5, advice that a particular qualified person does not want to receive notifications or that the capable adult receiving services objects to notice or objects to the provision of documents or information. And 6, a copy of the full investigative report with identifying names of employees. And finally, an appeals process has been added should a qualified person's request for documentation be denied by the provider. The process is as follows. A qualified person denied access to the records and documents requested pursuant to this section may appeal such denial in writing to the Office of Mental Health's Office of Quality Improvement. Upon receipt of the appeal, the agency issuing the denial will be notified of the appeal and given an opportunity to submit relevant information to the Office of Quality Improvement, including the reasons for denial, within 10 business days of the receipt of such appeal. The Office of Quality Improvement may also request additional information from the qualified person as may be necessary to resolve the appeal. Within 10 business days of the receipt of complete information, the Office of Quality Improvement will make a determination about whether the requested records and/or documents should be released. The Office of Quality Improvement will issue their determination with an explanation of the reasons for the determination to the qualified person and the agency. If so, directed by the Office of Quality Improvement, the agency must provide the requested records and/or documents to the requester. Note that records maintained by the agency may also be available under Section 496 of the Social Services Law to other persons named in the report as defined in Section 488 of the Social Services Law. The next section is Part 524.13 regarding the analysis, review, and monitoring of incidents. The first update clarifies that plans of correction or prevention, once developed and implemented, should be monitored for efficacy. The second area of change under this part pertains to the Incident Review Committee, or IRC. This section begins, as it did, stating that IRCs can be organized on a provider-wide, multi-program, or program-specific basis, and may have responsibilities other than those related to incident management. The part regarding membership is moved from this section and will show up later. This next section was added stating that a state oversight agency may allow a facility or provider's agency's IRC to be shared with another facility or provider agency, or IRC functions can be performed by another facility or provider agency on its behalf where a facility or provider agency is co-located within another organization or agency, or is part of a larger organization or agency, or has a larger parent or umbrella organization or agency. The Incident Review Committee section continues with the original language regarding the need for ensuring a free and open exchange of information and membership requirements. The membership requirements start out as they did before with members of the provider's governing body, direct support staff, licensed healthcare practitioners, service recipients, and representatives of family, consumer, and advocacy organizations. Incident Review Committee membership continues here with a change regarding the requirement for a physician on a regular membership or ad hoc basis. Now, a licensed healthcare practitioner can assume the role in the review of all medically related incidents. Section 4 clarifies the need to review any OMH-only reportable incidents in your Incident Review Committee meetings. And Section 7, regarding the maintenance of IRC meeting minutes, was updated to specify that an IRC's review of an incident is not considered complete until any plans of correction or prevention that have been developed in response to the review of an investigation have not only been developed and implemented, but also monitored. Therefore, an IRC's meeting minutes should include the monitoring outcomes of any corrective actions. Section 524.14, Special Investigations. This section reviews the incident types that require a special investigation, the highest level of investigation. It was updated to clarify that allegations of neglect also require this level of investigation, and 2 additional incident types were added to the list: inappropriate use of restraint or seclusion and financial exploitation. The final revised section, Part 524.15, reviews the expectations for employee code of conduct and training. Nothing has changed regarding the code of conduct for custodians. It is still required upon hire and annually thereafter. The required training for mandated reporters, however, has been updated to also be required upon hire and then annually thereafter. The additional revisions are meant to clarify the need to train staff regarding allegations of both abuse and neglect. Thank you so much for attending today's training. If there should be any additional questions, please feel free to contact us. Each region of the state and New York City borough has a dedicated clinical risk manager to assist in your agency's incident management program needs. If you're not familiar with your clinical risk manager, please contact our office by phone or email in order to connect with them.